everybody. Welcome to another Fireside Chat with Dr. Burnett. As you can see, we've got a little Halloween theme going this time. So, Dr. Burnett, there's been a lot of angst, I think, created by the trauma team changes at the hospital. Could you elaborate on that a little bit?
You know, as these nights get cold and the days get short, there's nothing I like talking about more than trauma team activations. We have changed some things at the hospital, as many of you know, so that we now have 2 levels of trauma team activation. And the reason we did this is that we found that there's a certain subset of patients where trauma teams were being activated that were not going directly to the operating room. And really that's the intent of the trauma team activation, is to have the surgeon in the emergency department so they can go straight to the operating room. For patients who we found don't go straight to the operating room, they always go to the CAT scanner to get their images, we don't need that surgeon in the emergency department on arrival. They're in the hospital, we can get them down there in 2 minutes if we need them. But if they're already in the operating room with a case, it's not better for them to leave that case to come to the ER if we know we're not going to need them right away. So since we don't need a surgeon in the ER right when the patient gets there for these cases, we tried to be more effective with their time. The challenge is, especially on the night shift, if the surgeon's in the operating room, they need to decide, do they come down to the ER for the next TTA or do they stay in the operating room? So the second tier of trauma team activation is designed so that the patient gets everything they need. Specifically, they get a dedicated ER team with a senior resident, the trauma nurse, so they have the most experienced emergency medicine providers, and then we get them right over to the CAT scanner, just like we would for a tier 1 trauma. That gets us the imaging we need to decide whether or not they need to go to the operating room right away. Now, it can be challenging for EMS, and we didn't want to introduce confusion by having you activate 2 levels of trauma. So what I would ask from you is, for EMS, nothing has changed. If the patient meets trauma team activation criteria, activate a trauma team. What I will tell you is, if a trauma team is activated, but the patient does not meet the predetermined tier 1 criteria like hypotension or GCS less than 14, that patient will automatically become a tier 2 TTA. We're not asking you to call tier 2 TTAs. If the patient doesn't meet tier 1 criteria, you can identify them as a red patient, and then the emergency medicine team will evaluate that patient and determine whether or not a tier 2 activation is necessary. We are going to make those decisions in the emergency department because there's real ramifications for calling a tier 2 TTA. It makes everyone else wait for that CAT scanner until that trauma patient has gone. And we may have other very sick patients who need imaging, patients with other concern for head bleed from a non-trauma, concern for pulmonary embolus, concern for perforated bowel. Those patients also need imaging very quickly. And so the decision as to whether or not to call a tier 2 TTA is going to be made at the physician level after evaluating the patient and taking into account how important is it for that patient to be the next in line for the CAT scanner. So from a pre-hospital perspective, if the patient meets TTA criteria, which have not changed, they're the same as they always have, call a TTA. If you're worried about that trauma patient, but they don't meet TTA criteria, identify that by saying they are a red patient. A red patient will get a quick evaluation by a doctor in the hospital. In that Regents, that physician will then decide whether to call a tier 2 TTA or to not call one. We are not asking pre-hospital providers to make that decision because it really comes down to knowing whether or not that patient needs to be the next one to the CAT scanner ahead of everyone else in the ER. And that decision can best be made by the ER physician.
Thank you. I think that's going to clear some things up for the crews and alleviate a little anxiety. Since we're talking trauma, maybe you'd like to talk a little bit about the whole blood program and its possible future.
Yes, whole blood. It is certainly the talk of the town right now, and appropriately so. It saves lives. It's pretty cool, and it's something I never knew if we would be able to get done even in my career. And look how fast things move. So whole blood is something that's getting a lot of attention right now. It's certainly when the right patients who are in hemorrhagic shock get it, they do better. The challenge with whole blood, which is unique to whole blood as opposed to our other medications, is that whole blood is a very limited resource. It just is not widely available. The blood banks that we work with, either Red Cross or Memorial Blood Centers, they struggle to maintain the donor population in our state, and that's a national problem. It's a challenge to get people to donate blood. And so having whole blood is really a luxury. Or we do not have a supply of whole blood in the state right now to put one unit on every ambulance. It's just not possible. It's a very scarce resource. And so we as EMS providers need to find a way where we can get the patients who need access to this limited resource access to it, while also maintaining that resource so that it's available. I think what we are going to see is that for services that have very high levels of trauma volume, they will likely be the services that are prioritized for whole blood. For services that don't have a high level of trauma volume, we're going to need to develop regionalized assets that can use this scarce resource and make it available to the most patients. That likely will not be that every service or every ambulance has whole blood, because again, there's not enough whole blood to go around. We're going to look to our services to develop innovative solutions to this problem by developing mutual aid systems for blood, ALS intercepts for blood, regionalized blood programs where departments will partner together and develop systems where when one department identifies a candidate for whole blood, they will utilize these mutual aid blood resources to get that blood to that patient. What I will tell you is for services that carry TXA right now, TXA is absolutely life-saving in this same patient population, the hemorrhagic traumatic shock patient. So as you and your service may be evaluating whether or not whole blood is right for you, I would ask you to look at how many times are you administering TXA to your patients. Those same patients who are getting TXA right now would be the candidates to get blood. So that will help you determine or get a sense of how often patients in your service area will require whole blood. Now, I've heard from some places that, well, there's patients that are candidates for whole blood that are kind of slipping through the cracks right now that we may be missing. And what I would say to you there is, with a resource as scarce as whole blood, we need to fix those cracks before we can deploy whole blood. We need to make sure that the patients who are candidates for TXA are getting TXA first. That is the proxy for the patients to get whole blood, because the indication would be traumatic hemorrhagic shock. Those patients would get both TXA and whole blood. So we can use our TXA administration metrics right now to determine how often TXA would be being used at the service level. And we can use that to help justify whether or not a very scarce resource is best positioned in a service's ambulances, or whether we should develop mutual aid systems so that several services who may individually have low administration rates of TXA jointly have very high administration rates, which could justify a mutual aid blood program. Please go donate blood. If you're watching this and you can donate blood, go donate blood. I donate blood about every 60 days, and it can make a huge difference in our community.
Very true. In fact, I think the first 2 or 3 administrations of blood in Lakeview service area were all mutual aid administrations. They weren't even for Lakeview ambulance patients.
I think that's absolutely correct. The one blood program we have live now with Lakeview, what we have absolutely seen is that mutual aid responses for blood administration have been common. And I do, to your point, think that reinforces the need to develop mutual aid systems for this very specific, very scarce resource.
Again, since we're still talking about trauma, there's been a little bit of discussion, and maybe it's been seen that C-collars haven't been used quite as much as they should. I know that there's been a lot of discussion about backboards are great for moving people, but not really for immobilizing people. Maybe you want to talk about that a little?
You know, the whole issue of spinal mobilization seems to wax and wane. It seems to be coming to the forefront again right now. What I can tell you is review our guideline, our patient care guideline in our online app or on our website is something to be familiar with. As Jason said, backboards are just used to move patients. Once you have a patient on your ambulance stretcher, you can remove them from the backboard. And I can tell you that when I'm taking interfacility transfers in my ED role, and I have somebody who's coming from maybe hours away by ground ambulance, I absolutely encourage that transferring hospital to lay the patient flat on the EMS backboard with a cervical collar on, but that they should not be on a backboard for a prolonged period of time. Now, when you think about the spine, the cervical spine is the most vulnerable. It's the part that moves the most. The thoracic spine, the lumbar spine, those are pretty well protected within the torso. But the motion that occurs around the cervical spine is what puts it at big risk. So what we have moved towards in our patient care guidelines is that a cervical collar does not need to be married to a backboard. I would say that any patient who's ambulatory at the scene, we do not have to have a rigorous level of immobilization for their thoracic or their lumbar spine. They could certainly still have a cervical spine injury though. So for that subgroup of patients, it would be very appropriate if they need a cervical collar to place them in a cervical collar, but to have them sitting upright on the cot. They don't have to lie flat. We should continue to have a low threshold to place a cervical collar. We should have a higher threshold for patients needing to lie flat on the stretcher because, as many of you know, we have lots of patients with COPD or CHF who lying flat is very difficult. Those same patients can tolerate a cervical collar sitting up very well. So for patients who are intoxicated or who have altered mental status, who have a mechanism of injury concerning for a cervical spine injury, it's very appropriate to put them in a cervical collar, but to have them sitting upright on the stretcher if we are not concerned about thoracic or lumbar spine injuries. Again, I would ask you to review your patient care guideline for guidance on the things we would look for to determine when they need to lay flat because we're concerned about thoracic or lumbar spine injuries, and when they can sit upright with a cervical collar. But again, please place cervical collars frequently. Please have patients lie flat on the bed, on the cot, only when necessary. We have patients that come to our waiting room who are complaining of neck pain, who have had a mechanism of injury concerning for cervical spine injury, who we will place in a cervical collar, but will continue to have them wait in the waiting room because we are not concerned about their thoracic or lumbar spine fractures. So if you do have a patient that you bring to the hospital who your concern is a cervical injury and they are in a cervical collar, it is acceptable for that patient to go to the waiting room as long as they are ambulatory without any concern for thoracic or lumbar spine injuries. I hope that helps to separate from what you might have learned in medic school or EMT school, that a cervical collar and a backboard go hand in hand, that no patient in a cervical collar could ever sit upright. I ask you to just think about how vulnerable the cervical spine is compared to the thoracic and the lumbar spine, which again are much more protected by the thorax as a whole.
Thank you, Dr. Burnett. I know that I had it beaten into submission, C-collar, half backboard, and it was a little ridiculous. So I had a couple questions, and I would like it if you would talk a little bit about droperidol use. Specifically, the question that we had was, could droperidol be used in a patient that was having alcohol withdrawal?
It's a great question. So droperidol is one of those 5 medicines, if I end up on a deserted island, that I would bring with me because it can be used for so many indications. In some of those indications, one of the effects of droperidol we take advantage of is sedation. Now, in other indications we use it for, perhaps for headache or vomiting, that sedation can sometimes be an unwanted side effect. And so what I would say to you is we get a lot of questions about using droperidol in the field for things we use it for in the hospital, like migraine headaches, like nausea. And what I can tell you is one of the reasons we don't authorize droperidol for all those indications we use it for in the hospital is that when you give it, you will predictably have a change in their mental status. They will get some sedation from that medication. And part of a robust neurologic exam is assessing someone's alertness, their orientation, and their level of consciousness. So it is challenging for us on the hospital side to be performing our initial neurologic exam on a patient and to find them to be sedated when we do not have that baseline to know what they were like before the medication was administered. That leads us to do unnecessary testing, like getting head CTs and things like that, where if we had been able to see the patient's baseline prior to medication administration, we would feel much more comfortable attributing their change in mental status to medication effect alone. So that's one reason we don't authorize droperidol to be used for things other than sedation, where we are trying to take advantage of one of its prominent effects, and we fully expect to have that effect as the outcome of administration. Now, as it relates to alcohol withdrawal, the main cause of alcohol withdrawal is an overstimulation of GABA receptors. And I don't know how I can get around this without talking about a little bit of receptor pharmacology. So, alcohol is a depressant medication. You have alcohol receptors in your brain, which are truly GABA receptors. And lots of things bind to GABA receptors. Alcohol is only one thing. It's not like there's a specific alcohol receptor itself. So what I said a second ago can be confusing. You have GABA receptors to which alcohol, as well as lots of other things, bind. Now, when you continuously activate those receptors because you're constantly having alcohol in your system, those depressant effects on the brain become the norm. And the brain gets used to that. And so if you rapidly withdraw that constant depressant effect that is there from the alcohol, you start to get an overwhelming stimulant effect because you've had constant depression effects that now are gone. And so that normal now looks like a huge stimulant. And you see all the things you see with alcohol withdrawal: fast heart rate, high blood pressure, sweating, agitation. You can even have a hyperthermic state where you raise the patient's blood pressure. You can have muscular overactivity that leads to rhabdomyolysis. The clinical picture of alcohol withdrawal is a stimulant. And so we do use droperidol for sedation in many other stimulant phases, as well as in undifferentiated agitation. If we don't know what's causing the agitation, droperidol is a fine choice. It's safe and it's effective. But droperidol doesn't bind. Yep.
That's a good spot.
Yeah, that's a good spot too.
I think that what I'll do is we'll finish droperidol. We'll talk about ketamine, and we got plenty, and then we can hang on to those other ones
For next time.
for the next.
What are we going to talk about with ketamine? Sedation, right?
Yeah.
Innovation. So droperidol by itself does not bind to the GABA receptor. It does not activate that receptor, and that's what we need to do to treat withdrawal. We need to activate that GABA receptor by replacing the alcohol with a medication. So the best ways to activate that GABA receptor with a medication are with benzodiazepines, like Versed in your case. We will often use a longer acting benzodiazepine in the hospital, like Valium. Ativan is another option, but that is currently on shortage right now. So in the pre-hospital environment, alcohol withdrawal, the agitation, the tachycardia, the hypertension that's associated with that can be appropriately treated with Versed. And right now, the patient care guideline I believe you would use for that would be the agitation guideline. We don't have a specific alcohol withdrawal guideline. You could certainly get orders from an online med control physician specifically for alcohol withdrawal if that's what you'd like. But if the patient is agitated and you assess that agitation is due to alcohol withdrawal, then your agitation guideline certainly authorizes droperidol as well as Versed. And in the case of alcohol withdrawal, Versed would be the more appropriate treatment. Now in the hospital, we do sometimes use droperidol or Haldol as an adjunct to benzodiazepines. We also use medications like barbiturates, like phenobarbital, to activate the GABA receptor. Again, there's a number of ways to activate that GABA receptor. Alcohol is one, benzodiazepines, barbiturates, those are all options. Propofol also activates the GABA receptor to a degree, but droperidol does not. Droperidol is a dopamine receptor blocker, a dopamine antagonist. So while we do sometimes use it in combination with agents to activate the GABA receptor in the hospital, I would not use it in isolation. Again, if we don't know what's causing the patient's agitation and it turns out to be alcohol withdrawal, droperidol is a fine choice to get sedation. Ultimately, we will be adding agents to that droperidol in the hospital to stimulate the GABA receptor, like benzodiazepines or like barbiturates, like phenobarbital, which has become a very effective treatment we use in the hospital. And just to touch on that, the reason for that is it has a very long half-life. Phenobarbital lasts for 3 to 4 days. And so it almost has its own built-in taper with it. When you get their symptoms of withdrawal under control with phenobarbital, you can basically stop giving them phenobarbital and it will slowly wear out of their system, in effect having its own taper, which is very nice and very easy for the patient to adapt to as they go through their withdrawals.
Thank you, Doc. I think the last thing we want to talk about is there's been some discussion and some crews, and I understand why. After they've gotten an advanced airway in place, they've gone through their RSI procedure or RSA procedure, they've done their induction, their paralytic. For post-management sedation and pain management, they'll just go with a dose of ketamine. Is there a preference? I know within the guideline that's a possibility, but would you discuss that a little bit?
You know, if we didn't work with drug shortages and ketamine was always going to be available, I'd say that's a fine choice. There's no reason not to. And if you have a vial of ketamine that you have drawn from to administer RSI and to put the patient to sleep during your RSI procedure, and that ketamine is just going to get wasted, then I think that's a fine choice. My concern is we've seen multiple times where ketamine has gone on shortage, and we really have no substitute other than etomidate to put that patient to sleep, to put the breathing tube in. We also had no substitute for ketamine for some of our behavioral emergencies as outlined in your behavioral emergencies guideline. So ketamine is something we really try to protect and to save for those indications where there's no other option. Now there is another option for post-intubation sedation. As long as the patient's not hypotensive, it's perfectly reasonable to give them fentanyl and Versed to both sedate them with the Versed as well as to control their pain with the opiate. Ketamine, as you know, is a 2-for-1. It's both a sedative and an analgesic. That's one of the very attractive pharmacologic properties of that medication. So I can't tell you it's wrong to use ketamine as post-intubation sedation. If you have a vial of ketamine where there's ketamine left that you're just going to waste, I think that's a fine choice to administer to your patient as a post-intubation sedation agent. It's a pain control agent and a sedative. If, however, you have to open a new vial of ketamine to give for sedation and the patient has a normal blood pressure, I'd ask that you reserve that ketamine for other uses where we have nothing that can be used in its replacement. In those patients, I'd ask you to use fentanyl and Versed. And which you administer first, I think, comes a lot down to what you think is stimulating that patient. If it's a trauma patient who might have fractures, pain is likely what's driving that patient to wake up. And so it may be very reasonable to give fentanyl as your first agent after you intubate them to help keep them calm and tolerate the endotracheal tube. If it's a patient who may have a stimulant drug on board, or who has an overactive thyroid gland, or who maybe has altered mental status from an infection, in those cases, pain may not be the main thing driving them to wake up. And so giving your sedative first in the form of Versed would likely be a better choice. Now, in either instance, whenever you give first, I would encourage you to use the alternate class of drugs second, because both pain and agitation drive people to wake up. So if you give Versed first because you're intubating this patient due to infection, which has caused them to have acute respiratory failure. Even though you use Versed first, if you need to give additional medication, I'd encourage you to give fentanyl on top. Now, if you give fentanyl first, because perhaps it's a trauma patient with extremity fractures, even though you've addressed their pain, they might still wake up. And in that case, I think it's reasonable to administer a sedative in the form of Versed next. Now, if their blood pressure is low, and I would say low being less than 90, at that point, I do think you have only one right choice, and that's going to be ketamine. So in that case, where their blood pressure is low, even if you have to open another vial of ketamine, there's really nothing we have that's better than ketamine at that point. So at that point, use your ketamine. But if they have a normal blood pressure after you intubate them, and if you would have to open a new vial of ketamine to get more, I would ask you to not do that and to use fentanyl and Versed. Again, if you have leftover ketamine in your vial that you're anticipating you're just going to waste, I think it's personally reasonable and very patient-centered to use that medication as your post-intubation sedation.
Thank you. As always, it's been a pleasure, especially with our little pumpkins in the background. Anything else for the cruise, Doc?
Happy Halloween!